Greetings everybody. I welcome you all to the second annual virtual conference on early childhood caries. The next lecture is going to be on association between early childhood caries and iron deficiency anemia. So the contents of my presentation include introduction, need for the study, methodology, results, discussion, conclusion, implications for future research, followed by the references. Moving on to the introduction. Fitz et al. Defines ECC as the presence of one or more decade, missing or filled surfaces in any primary tooth of a child less than 6 years of age. More than 600 million children worldwide are being affected by ECC, and it remains the most prevalent disease in children with a significant impact on their growth and development. Similar to ECC, iron deficiency anemia is another commonly prevalent disease in children. World Health Organization defines iron deficiency anemia as a condition in which there are no mobilizable iron stores, with signs of compromised iron supply of iron to tissues and severe stages of iron deficiency being associated with anemia. It is recognized as the most common and widespread nutritional deficiency, affecting about 1.62 billion people worldwide, with the highest prevalence of 47.4% in preschool children. Iron deficiency anemia causes irreversible short and long-term damages in the developing central nervous system of children, resulting in cognitive and motor disabilities, thus affecting the quality of life. With diet being strongly associated with ECC and IDA, we propose that a relationship may exist between these two entities. Regardless of the pervasive nature of both ECC and IDA, limited research exists to corroborate an association between these two. Few authors are in support of a potentially positive association between these two entities, with ECC as a risk factor for IDA. However, few authors are completely against this and propose them to be two separate entities with no existing association between these two. With existing literature, it has been challenging to arrive at a definitive understanding of this cycle, and thus the association between ECC and IDA remains ambiguous. However, identification of this oral systemic relationship will aid pediatricians, pediatric dentists, healthcare policymakers, and family physicians in enhancing the current preventive and health promotion measures to reduce the burden of ECC and IDA in children. Thus, this review was aimed to evaluate the association between ECC and IDA with the available literature. This review was registered in the Prospero International Prospective Register of Systematic Reviews, and reporting was done in accordance with the PRISMA guidelines. The research question was: is ECC associated with IDA in children aged 0 to 6 years? The population included children from 0 to 6 years of age. Exposure as the presence of ECC, comparison as the absence of ECC, outcome as IDA as assessed by hemoglobin, serum ferritin, and mean corpuscular value. This study included cross-sectional, case control, and cohort studies in English from 1998 up to May 2020. The mesh terms used were child, preschooler, infant, dental caries, iron deficiency, and anemia. Search was done in Medline via PubMed, Embase, Lilacs, Cochrane, Sinhal, Web of Science, and Scopus. The quality assessment of the included studies was done using the Newcastle-Ottawa scale for case control and cohort studies and modified Newcastle-Ottawa scale for the cross-sectional studies. The grading of recommendation, assessment, development, and evaluation was used to assess the certainty of evidence, whereas data analysis was done using Review Manager software version 5.4. Heterogeneity was assessed by means of chi-square and I-square tests. Moving on to the results. The PRISMA flowchart explains the study selection process. The search yielded a total of 1,434 articles, 1,254 through electronic database and 180 through other sources. Following exclusion at various criteria, 14 studies were included in the qualitative analysis, while 7 studies provided data sufficient for meta-analysis. Moving on to the study characteristics, the 14 included articles include 1 cohort, 3 case control, and 10 cross-sectional studies. This review included data of 1,770 participants with 1,364 cases and 406 controls without ECC. The included age limit was from 18 to 72 months. Hemoglobin was considered as a parameter in 13 studies, serum ferritin in 10 studies, and mean corpuscular volume in 12 studies. The qualitative assessment of the studies, which were done using Newcastle-Ottawa scale and modified Newcastle-Ottawa scale, revealed a high risk of bias, elucidating low quality, which was demonstrated in 2 cross-sectional studies, and moderate risk of bias, implying moderate quality, was demonstrated in 1 cohort, 3 case control, and 8 cross-sectional studies. The grade assessment, which was used to assess the certainty, revealed a strong evidence for association between iron deficiency anemia and ECC, whereas a very low evidence was assessed on the association between hemoglobin, serum ferritin, mean corpuscular volume, and early childhood caries. As mentioned earlier, 7 studies from the included 14 studies provided data sufficient for the conduct of meta-analysis. The analysis on iron deficiency anemia outcome between ECC affected group and ECC non-affected group revealed higher odds with an odds ratio of 6 among the ECC affected group. Heterogeneity was not detected among the included studies, hence a fixed effect model of meta-analysis was used for this particular analysis. On the quantitative analysis comparing hemoglobin values between children with and without ECC, no statistically significant difference could be detected. However, lower levels of hemoglobins were seen in the ECC group than in the non-affected ECC group. Because of higher heterogeneity, a random effect meta-analysis was performed. Moving on to the quantitative analysis on serum ferritin between children with and without ECC, 4 included studies reveal no statistically significant difference between these two groups. 3 studies which compare the mean corpuscular values between the comparison and the control groups reveal no statistically significant association. Now move on to the discussion part. The present systematic review was undertaken in a structured approach to identify pertinent literature examining the correlation between ECC and IDA. Meta-analysis revealed higher odds of iron deficiency anemia among children affected by ECC. Quantitative analysis comparing hemoglobin levels in children with and without ECC revealed no statistically significant association. However, this could be attributed to various confounding factors such as no standardized cutoff values and varied sample population. Shaw et al. Hypothesized the association between hemoglobin levels and ECC to the inflammatory response of the body to rampant caries. Associated inflammation with ECC triggers a cascade of reaction which leads to cytokine release that in turn inhibits erythropoiesis, leading to reduced hemoglobin levels. Occult blood loss due to inflammatory process in addition also influences the blood parameters. Altered sleeping pattern due to nocturnal pain leads to decreased glucocorticosteroid production, which in turn further influences the iron levels. In a study by Shaw et al., a significant difference in the values of hemoglobin, serum ferritin, and mean corpuscular values was reported 4 to 6 months following dental rehabilitation in children with ECC. The author concludes that resolution of ECC leads to parallel resolution of iron deficiency anemia without treatment for iron deficiency. This was again confirmed in a similar study by Nagarajan et al. Elevated hematological parameters could be due to the cessation of pain and improvement in nutritional status following dental rehabilitation. However, one should note that both the hemoglobin parameters in both the studies were indicated a mild form of anemia as predefined by WHO. These results are to be interpreted with caution as both these studies reported moderate risk of bias. Hence, further evidence-based longitudinal research with robust methodology is imperative to confirm whether total rehabilitation of ECC alone would be adequate for management of children with ECC and IDA. Early childhood caries has an impact on the child's overall health-related quality of life, growth, development, and well-being. Untreated caries and associated infection can cause pain, discomfort, and reduced food intake, leading to decreased consumption of iron-rich foods such as meats and nuts. The child tends to satisfy hunger with excessive consumption of bovine milk or sugar-rich beverages. Bovine milk can impair iron absorption in children due to the casein and calcium which is present. There are reports of child having developed IDA owing to the occult intestinal blood loss on excessive consumption of bovine's milk. Therefore, excessive consumption of cow's milk and decreased intake of iron-rich foods due to masticatory pain might have an impact on the iron stores in the body. Bonek and Kahn reported that prolonged bottle use, which is a risk factor for ECC, is associated with increased risk of IDA since children become habituated to drinking milk or sugary drinks rather than consuming a well-balanced diet. Prolonged bottle use could also be another common explanatory variable for both ECC and IDA. However, this has not been considered in any of the included studies. Iron deficiency, a form of micronutrient malnutrition, is said to have an adverse effect on the quality and quantity of saliva in early childhood. Reduced salivary flow affects the buffering capacity of saliva, thereby inhibiting its caries preventive action. Bahadilla et al. Reported increased caries susceptibility among children affected with IDA. Iron has a karyostatic effect due to protective acid resistant coating, which in turn prevents further dissolution of enamel. Iron, in addition, is also said to have a significant inhibitory effect on the growth of Streptococcus mutans, the early establishment of which is directly related to the severity of dental caries. Early childhood caries and iron deficiency anemia both are multifactorial diseases which are influenced by underlying social determinants of health such as socio-economic status. A cause and effect relation can be determined only if all the confounding factors are taken into consideration, as these factors mask the true association between these two entities. Previous studies have established the impact of low socio-economic status in both ECC and IDA. Thus, socio-economic status not being considered a majority of the included studies may compromise the validity of these studies. Socioeconomic status was assessed only in 5 of the included studies but was adjusted in only 2. Confounding factors can exert a distorting influence and therefore should be minimized. Meta-analysis adjusted for socio-economic status revealed an odds ratio of 5.29. Diet has been considered in only 3 of the included studies, but neither adjustment nor correlations have been attempted to explain its association to ECC and IDA. Few impediments in our study was the inclusion of cross-sectional studies, which present with a lower quality of evidence. A cause and effect relationship was difficult to ascertain, and its interpretation was limited by potential confounding factors such as diet and low socioeconomic status. The direction of association thus could not be inferred from the available studies. The studies varied with regard to the sample's age, culture, the index used for reporting ECC, and parameters for assessing IDA. The included studies could not and did not make an attempt to identify the plausible mechanism between ECC and IDA. Moving on to the conclusion. This systematic review demonstrates an association between early childhood caries and increased odds of iron deficiency anemia rather than it being the cause of IDA. The results presented here establish the importance of awareness of this oral systemic relationship among physicians and dentists treating young children. Nutritional deficiencies should alert the healthcare provider of the possibility of ECC, which could be a potential explanation for nutritional impairment in these patients. For dental professionals, ECC affected children should be considered for nutritional deficiencies that may impact their long-term health and well-being. Based on the conventional risk factor approach for infants and children, recognizing this relationship could help design feasible and optimal preventive strategies worldwide. The cause and effect or the direction of association could not be inferred between ECC and IDA. Hence, in future, prospective studies with robust methodology are required to determine whether children with ECC may be more vulnerable to IDA and to further evaluate the temporal association implying causality. Our study is accepted for publication by Caries Research. These are the references. I would like to extend my sincere gratitude to Team Sikri and my mentor and guide Dr. Muthu sir for giving me this opportunity. Thank you.